Our next speaker is Dr. Richard Warnecke from the University of Illinois at Chicago. He is Professor Emeritus of Epidemiology, Sociology, and Public Administration, and a co-director of one of 10 centers of population health and health disparities. Let me get his talk up for him. And the title of his talk is Thinking About Health Disparities Research, Our Approach at the University of Illinois Center for Population Health and Health Disparities. Welcome, Dr. Warnecke.
What do I do here?
We have this. Do you want to just hit the buttons?
This button?
I think so.
Yeah, there we go.
There we go. Okay.
Thank you. I'm very happy to be here. And it feels like home. University of Illinois at Chicago is very much like this.
Can you all
a little older, but similar in character and aspirations.
The mic on, you're not hearing me very well.
Okay.
Sorry, we're going to mic in.
That means I can walk around.
Yeah, now you can walk around.
What I'd like to do is talk a little bit about how we conceptualized health disparities and how actually the first program was funded by NCI and the National Institute of Environmental Health and the National Institute of Aging, and we've always had help from the Office of Behavioral and Social Science Research. But so we developed a model there jointly, which I'll talk about in a minute, and then talk about the goals and organization of our particular center, what happened in the first 5 years, what's going on now, and what we hope to do next. My thinking about health disparities is not very innovative and not very different from what Dr. Satcher said and what others have said. I liked Fielding's comment about the fact that we need to focus on upstream determinants of health rather than at the individual level, and that policy is really critical, and you've heard that before today too. Specifically, I think determinants of health disparities are only understood from a population standpoint. Studying individuals gives you insight into things, but it really doesn't help addressing this issue of disparities. And they differ from determinants of population health, and my talk is going to be around one big example of that. And finally, they must ultimately be systemic or at least multi-level. And again, that's not a great breathtaking resolution. So determinants of population health focus on improving the health of the population. And you've heard a lot about that. But they don't address typically differences among subpopulations. They're designed to improve health in general. So smoking cessation, early detection, and so forth, those are population health things that are very good. But their effect is intended to be universal. Determinants of health disparities are two kinds, and this is where I may differ from some. I think biological, sociocultural, shared beliefs, and even certain systemic issues are differences. They're not necessarily disparities. They become disparities when, because of the position of a subset in that population, people occupy different levels of social hierarchy. So I like the British discussion of inequities, and that's really what I'm going to talk about. They result from events or policy over which those experiencing the disparity have really very little control. And the problem of lack of control is this difference in where they are and who they interact with. So unequal treatment due to racism, due to ethnic differences, due to lack of resources, or mainly due to policy and social status. I think that our policies generally tend to focus on everyone and ignore the fact that not everyone can participate equally. And the Affordable Care Act actually provides a really good example of that, among others, and I'll mention that. So multi-level is important. That is, you can't think about it at the individual level. people experience it at one level. I think the next, yeah. This is the model that we developed as a group, and I can talk about it better from here. I think I'm a big believer in for those of you that read the sociological literature, at least know about fundamental causes and Lincoln Phelan at Columbia. I think that's really the ultimate place that has to be focused, and that's where policies are, and that's where policies develop institutions. So the medical care institution, the religious institution, the family as an institution, they are the factors that influence, I think, what happens in terms of where you get it. And it's experienced in the middle, in where you are, in your community, in your family, in your church or synagogue or temple or mosque or wherever, and in your social relationships. And so patterns of social organization really are the place where things happen, and they're the place where most of us who work in disparities ultimately end up. And then things like individual characteristics and biological characteristics are the sources of difference, definitely. And whether or not they're addressed. I mean, even genetic differences can be differentially managed. I mean, there are a few where 100% of the people who have it, and there's not much you can do about it. But even there, I mean, I have a son-in-law who has Huntington's, and the difference between his life experience and his father's, who also had it, is amazing, because he's in a trial that's helping him cope with it. Advanced breast cancer. Women now are living with advanced breast cancer and living normal lives, or relatively normal lives. So even where you have a genetic problem, if you're in the right place in that system, you're going to get opportunities to address it and mitigate it. If you're not in the right place, you're not. You're going to just live it as a natural event. So I like this. There are the ecological models with circles running around them and everything, but to me this reflects process, and it does move back and forth, but the ultimate governing principle, I think, is really whether or not policies are designed to promote and address differences. This was the disparity in Chicago, mammography, breast cancer mortality, actually. And that's an example of a public health measure that has been remarkably successful up until now. And the thing that we notice is that the African American line, which is the top line, the box line, it stayed level, but the white line decreased. And it started around 1990, and those of you, I don't know how many of you do cancer, but if you have, you know that 1990 was when many of the breakthroughs occurred in chemotherapy, in surgery, and also in early detection and prevention, and also they were discovering new things about mammography or how to detect cancer. So we decided that this was the issue. The article that has this diagram in it was published about the time that we were starting our work. And so along with what we were doing, not determined by us but with us, was the formation of a coalition in Chicago to address disparities in breast cancer. And at the same time that was happening, as you can see, the mammography experience was improving, at least according to the National Health Interview Survey during those periods. Whether or not it was improving at the same rate and with the same quality, it became the issue that we ended up looking at, and where you were and how you entered the healthcare system had a lot to do with that. So our overall focus in the initial 5 years was understanding this disconnect between rates of screening and stage of diagnosis, and we had, I'll tell you in a minute, 4 projects that looked at that. Currently, we are using 3 projects to explore things that we found as a result of our first 5 years. And our next step will be to try to understand how the Affordable Care Act can actually have an impact, at least on our healthcare system, and hopefully it's a generalizable model. So we started with and our general goals are to examine why, when rates of mammography are approaching equivalence, prognosis of diagnosed cancers is among African American and Hispanic women is poorer than for Caucasian women. How trust in the healthcare system and extent of contact with the healthcare system affects the likelihood of breast cancer detection through screening mammography, and exploring the interaction between biological markers of stress, tumor aggressiveness, and community residence on the probability of late-stage diagnosis, and how social environment at both the level of the social network and the community affects whether she's diagnosed, treated, and consistently with current guidelines, and to develop and maintain a strong interaction with the community. So these are the projects that we had. We had one that studied neighborhood. It was built on the progress in human development in Chicago neighborhoods, which you may be familiar with the work of Robert Sampson and others at Michigan. And well, they're all over the place. They're all at Harvard now, I think. Social networks, which we decided that we really wanted to collect not only data on individual social networks, but we were going to, as part of the data collection process, collect names of members of the social networks and contact them and interview them to see a better picture of how the network system actually worked. We had a small project looking at individuals who were waiting for diagnosis to get some information about how they arrived at diagnosis and how they for it. And then mainly what we did was we did this major survey of just under 1,000 cancer patients that were ascertained by our registry shortly after diagnosis, to look at the process from detection through management. And we're still working on all this. But we figured that through this we might have some idea of what kind of factors affect stage of diagnosis. Before we submitted the proposal, we had we'd had a REACH program, we'd had some other programs, and there's some dissonance in the community about the way they were handled. So we decided that maybe we should sit down with some people from the community and some people who participated in these programs and see if we could arrive at some kind of an understanding as to what doing research with people of color in the community might imply. And they told us, and we told them what we were interested in doing if they were interested in helping us. They told us what they wanted, and they wanted to be true partners. They wanted regular participation in project meetings and would help instrument the development and interpretation of results into the community. They specifically wanted to learn how to write grants, actually, and that turned out to be a major factor. It was the beginning of the period where funding was available to community groups to get things, and they wanted to be part of that. They expected financial support to ensure that they had the right people in the right places. They informed us that a lot of people think that because they're poor, they have lots of time, and they told us that was their best asset, and we agreed. And they wanted to see an outcome that they could explain and that they were visibly part of the outcome. So they became actively involved. We budgeted for one coalition to be a major piece of the activity, and that worked pretty well. That person who got that funding, or that organization, actually divided it, so we had an African American coalition and a Latino coalition, which turned out to be very important, particularly as we developed the instruments for the survey and so forth. We had good participation. We also would go to their meetings. They would have meetings, and we would attend them in their communities, and we met people. That's continuing as part of this coalition, actually, that was formed. And that the analyses were presented at these meetings, and the results, or our interpretation of the results, were vetted with our partners. So when we found associations between cultural beliefs and other kinds of things like that, instead of just going ahead, we presented them to them and said, does this sound like something that makes sense to you? And we followed their advice on how we handled that. So when we began planning for the renewal, we met again and presented the results and said, this is what we think we need to do next, and they agreed to help us with that. So this is just an example of the different kinds of data that we used to put together. Actually, the survey took most of the 5 years. Since stage of diagnosis was our outcome, by the time we identified the patients received their treatment, and finally the stage got into the medical record. It was almost 9 months, and to get the patients, I think we finished the survey about 6 months before the end of the first year period. So a lot of the work we did in the beginning was with the cancer registry and with other data sets. Some of the findings that came from that were, first, that at any age, African American women were more likely to be diagnosed with a later stage than white women. A similar pattern, we replicated this with registry data from 6 other cities. In some cases, they were mostly Hispanic. In some cases, they were mostly African American. But it replicated. But the interesting thing was that we could not find, once you introduce poverty into the equation, you could not find race anymore being a predictor of this disparity. It was pretty much explained by poverty, except for African American and Hispanic women under the age of 40, where the early aggressive forms of breast cancer occur. And in that case, there was an interaction between race, ethnicity, and stage of diagnosis, which became the basis of one of our projects in the second year, or grant. And women who lived through disruption of gentrification or increased migration did not benefit from the upgrading of their areas. They were 10% more likely than women living in stable neighborhoods, regardless of socioeconomic level, to be diagnosed with advanced cancer. This is an interesting piece of information that came from, because the University of Chicago got a center the same time we did, and they also ended up studying breast cancer. I was amazed that we both got funded in the same city and by the same institutions. But as you'll notice on the bottom, she found, with a very small group of patients, about 250 patients, direct correlations between biological markers for aggressive cancer and various neighborhood and personal characteristics, depression, social isolation, and especially sexual assault. And one of the things that I was saying last night was that I think it would be interesting to see, because these aggressive cancers, the BRCA1 and BRCA2, are said to originate with populations in Eastern Europe, primarily Jewish, I think. But in Africa, the average age for onset of breast cancer is 30. And in both cases, and in the women in our own country, I think, that live in some of these neighborhoods, the treatments, sexual abuse, physical abuse, and so forth, are common factors. And so it could be that we're saying now that the changes or the aggressive cancers in young women in the United States are somatic. That is, they're not all familial, although some of them are. But it would be an interesting thing to look at, to see whether or not all of these populations that young women in particular experience severe aggression as they move into urban areas and or as they are assaulted by groups. If you find a change that began as somatic and eventually became heritable, which happens. So our other finding that has governed a lot of what we're thinking about now is that we started looking at medically underserved areas and people who live in those areas. We have an interesting situation in Chicago where we have some areas that are eligible for designation as being medically underserved, but have never applied for it, so have never gotten the funding. And they're interspersed, not for a while yet, they're interspersed with areas that have been designated, and they're particularly in the south part of the city where there are very few medical services. If you look at Chicago in the north and western areas, that's where all the medical centers are, that's where a lot of the community hospitals are. Whereas in the South, they have some community hospitals, but not nearly as many, and no major medical centers after you pass the University of Chicago, which is really more north than south. So those of you that don't know, being designated, you have to have 4 things: population in poverty, infant mortality, percent of people over age 65, and medical providers per population. You also have to apply for designation. And so all of our patients were geocoded into those areas. And from various analyses, we found that women who lived in these areas were about half as likely as women who lived in the ineligible areas to present with half stage. In other words, they benefited from living in those areas in terms of their likelihood of presenting with a stage of diagnosis, even though their sociodemographics, we did a propensity analysis to look at this, so we matched very closely. And what we found is that they even use the same clinics. So I don't think it's the clinics. But what we also have found is that, well, this is why it's important for the Affordable Care Act, because this is the main intervention to provide these Medicaid, newly covered Medicaid people with health care, is through these primary health centers in the community. But they don't seem to be well linked into medical systems. And for breast cancer, for example, most of them have to refer somewhere for a mammogram. And when they do that, they lose the patient. As far as they know, they've referred them. They have no idea, they really don't have very much information about the results, and even if they get the results, they have no idea what happens to the patient. So the lack of integration of these clinics into medical systems, I think, is going to be a really big problem in implementing this Affordable Care Act, if this is true across the country. It certainly is true in Chicago. So if you see this map, the pink areas are the undesignated areas that are eligible. The yellow areas are old areas that were designated before 2000, and the green areas that are designated after 2000. And there isn't much difference, actually, between the newly designated and the others. We did find that the women in the eligible but undesignated areas are less likely to be diagnosed with early stage and more likely to be diagnosed with late stage. We found that there was a significant difference between the eligible and ineligible. Now, the ineligible are areas that don't qualify for designation under any circumstances. And interestingly enough, the undesignated areas are predominantly African American. So when we did the propensity analysis, we couldn't include the Hispanic people who lived in the designated areas because we couldn't match them with people in the undesignated areas. So, but we found that they're poor and lack education, which is not surprising. We also found that they had poor perceptions on these neighborhood markers that were used for the Human Development in Chicago neighborhood. And these were statistically significant. So the neighborhood disorganization is very common in all of these eligible areas. This is a complicated slide, and the main point is that they're more likely to be uninsured. They're more likely to not have a physical exam in the previous 2 years. They're more likely not to have a mammogram, and they're likely to get their mammography in either public safety net institutions or small private hospitals, and more likely to be detected by non-radiologic means, and are more likely to spend more time in the system from detection to actually treatment. So there's some evidence that women in these MUA eligible areas are at a disadvantage in terms of how their cancer is managed when it's found. Interestingly enough, both groups, both the designated and the undesignated eligible groups, are more likely to have their cancers detected clinically, that is with a lump or some similar symptom, rather than radiologically. But and still the women in the designated areas do better, which leads me to think that there's more to it than just mammography, which is what we're exploring next. So as we moved into the new P50, we're interested in examining interventions in local safety net hospitals and community health centers that might address disparities in stage, pursue a potential relationship between DNA. This is one of we collected blood and tissue in the interview as well as doing the interview, and we have a project looking at DNA methylation and tumor aggressiveness, partly based on some of Sarah Gillett's work from Washington U and others showing that aggression really is a part of it because it's part of the inflammatory response of the body to stress. And then through the community partners, communicate the results in ways that impact policy and assure equal access. By the time we got to this Metropolitan Chicago Breast Cancer Task Force had been in operation, and so we have been working with them in the areas of policy. We also want to enable those at risk for late-stage diagnosis to make more effective use of the services that are available and establish a program at UIC that goes beyond breast cancer and provides training for new investigators. So the first study is a patient navigation study. It's part of the patient navigation, it's an outgrowth of the patient navigation, special patient navigation project that was introduced earlier. But we're looking, this is a randomized trial where women who come in for physical exams in federally qualified hospitals, safety net hospitals, are randomized to navigation or no navigation, and then followed to see whether or not navigation improves the likelihood that they will get their breast cancers detected. And we're about halfway through with that. We're also, of course, looking at barriers, identifying social, psychological, and screening history and so forth, and assess patient satisfaction with care. And we are doing a cost-effectiveness study. The second project deals with assessing risk. Our question was, could we introduce screening for high risk in a federally qualified health center system? And the investigator on this is an oncologist who's developed a predictive model for early detection of breast cancer that goes beyond the existing models that have been used and focuses more on family pedigree. And he's testing both a chemotherapeutic intervention, SERMs, using raloxifene and tamoxifen, as well as enhanced screening, lifestyle changes. And he's trying to classify women into population level risk, moderate risk, and then very, very high risk, these familial cancers. He is now head of a new center at UIC that is focused on familial risk for breast cancer. And actually, he's head of the breast cancer service. So his aims are around risk, whether or not the doctors in the clinics will assess risk, or whether or not the women whose risk is assessed genetically and so forth want to know this information, whether or not they object to having their tests done, because the doctors are doing it as a matter of policy, so it's not a question of, it's part of the standard of care to assess the risk. So, but then whether or not they will participate in programs to monitor that risk and to see if we can mitigate the results of that by various means. And the ultimate goal is to build a cohort and biorepository for the history of these women. The third is the DNA methylation study, and mainly the interest for purposes of this talk is that it characterizes breast cancers by their likelihood of getting how DNA methylation is related to breast cancer aggressiveness. That's the model that he's looking at. He's seeing methylation and psychosocial stress as mitigation, or as mediation and moderation between ethnicity and aggression. So the data compiled by, I want to talk a little bit about this task force, because they did that first study, and they've done several studies after that looking at the changes in risk and comparing the risk in Chicago to risk in other cities for mortality for breast cancer. I think we ranked third highest after two other cities, and I think they're Detroit and Baltimore, but I'm not sure. So they presented an initial report at a press conference, and they got support from Komen and ACS, and the General Assembly of Illinois passed a law called the Reducing Breast Cancer Disparities Act. And the most important part of this is that it established a data quality consortium, and the Medicaid program in Illinois told mammogram providers that if they wanted to get this Medicaid surplus for, or higher payment, Medicaid benefit for early detection, they had to report their quality data. Otherwise, they wouldn't get it. And so they are getting it from about 55 hospitals, I think, now out of the 70 in Chicago, and many of them are the safety net hospitals. So that's one outcome that can happen from community organization. Our partners, our community partners, were very instrumental in part of this development. So I mentioned this earlier, this disparity, and the graph shows clearly that that what was wrong with this system was not that cancers weren't being detected, or maybe they were, maybe some weren't being detected, but that the situation wasn't getting worse for women of color. It just didn't change. Whereas for white women, it changed, and it changed for the better. So our current thoughts now are to begin to look at a system. As it happens, our university has decided to integrate its clinics, which are federally qualified health centers, and several community hospitals more closely into the healthcare delivery of our university. Our University of Illinois Medical Center is the second highest, or second or third highest provider of care for minority populations. We actually like to get Medicaid patients. It's a good thing for us, whereas some of the other bigger hospitals would prefer to have private insurers. So getting people to come in, because we think that the entry point for this are these federally qualified health centers, and that if we can get the physicians and other health providers in those centers to be more integrated, to learn more about the new innovations. I think that one of the problems here is that the information about new treatment and so forth isn't being disseminated in a way that these doctors at the community level, and even in some of the community oncology programs, are able or know enough to implement the procedures. And that seems to be proof from the evidence. The Cancer Institute has actually been experimenting with what they call community comprehensive cancer centers, and find that when they intervene properly, they get the same quality of care that that the university or the high-level medical centers get. So we're going to try and do that. I just happened to decide to do this at a time when this change was happening, and so they were very happy to hear that this was going to happen. So what we're going to do is apply to one of these PO1 or R1 applications for dissemination and implementation grants to try and implement that into the hospital. And we'll start by meeting with these community providers at these clinics that are part of our system to find out what their perceptions are about what we think is happening there, based on not very good data, actually. In fact, our own clinics didn't respond to our survey of federally qualified health centers. So it'll be an interesting experience. And so what we want to do is set up electronic EMR referral systems where doctors can consult with either people at our institution that have current knowledge of the standard of care, or through people in our institution, other people in the thing, but using the EMR as a way of easing the referral issues, and linking these centers to primary care. The second thing we're going to do is run a series of continuing medical education programs and involve these doctors in practice-based research, which we know they'd like to be involved in, and give them resources in terms of data managers and clinic navigators to bring people in. I mean, the problem with that study that I was talking about looking at risk is that 50% of the women that are scheduled for physical exams don't show up for the physical exam. We are finding in the navigation study in the first project that a navigator has been able to improve that level of participation. That is by contacting the woman, reminding her of her appointment, addressing barriers at that point. They come in, and they come in at a higher rate, not 100%. It's just like your problem with getting students to graduate. It takes time. But if they have assurance, and one of the things that they say is that if they have somebody to talk to that looks like them and has experience like them, they're more interested in it. That's what they also told the people in this risk program that we had. We also were concerned, by the way, in this risk program about the ethics of doing genetic screening without telling the person beforehand. And it turns out that it isn't an issue. We got a supplement from OBSSR to actually study women's reactions to this, whether or not they wanted to know of their risk. And 95% of the women who were interviewed, and they didn't know that this, because the doctor would do this screening and wouldn't necessarily tell the woman unless she wanted to know. So that as part of the workup, he would do a history, which basically tells the risk. And it's working very well. 95% of the women want to know the risk. 68% of those 95%, this is half of the women that could be in the study because the other half didn't come for their physical. But anyway, 68% of those that know are interested in participating in some kind of a program for risk reduction. So we have some hope that with this procedure, and if we if we institute this, we also will be able to maybe provide more concrete information about why people of color don't participate in clinical trials at the same level as whites. Now, even white populations, only about 10% of the people that are eligible for trials go on. So this business about participating in clinical trials is more complicated than just, it's certainly not due to race by itself. But trust is very important. And if you have people, I mean, we had focus groups of women telling us about these experiences where Hispanic women would come in, a mother and daughter in one case, and nobody on the staff could communicate with the woman. She had some kind of intestinal, and so the daughter had to give her mother an enema, and this was a really difficult thing for the daughter to do, embarrassing, and for the mother, degrading. You have these kind of experiences. I'm sure if you have Hispanic clinics here in Atlanta or wherever you are, that you've heard similar kinds of stories because they're just not staffed with people that really are able to talk to the patients that come in, which is one of the reasons why you don't necessarily get the best reaction. So if we don't pay attention to the linkage, which is really my concern, to the linkage between these primary healthcare centers, it'll be just like the emergency room, where people come in, they get whatever it is that's treated, and then off they go someplace else. Some of the clinics have done very good jobs with this, just like, and do have integrated relationships, some of the ones in Chicago, which is why we know that maybe this is a possible way to address this. So we're interested ultimately in addressing this way. And we feel that there is a need to integrate these clinics. We feel that there's a need to use technology to facilitate referrals, navigation to help patients get through the system and overcome the barriers, involve community docs in networks where they hear about the innovations, and then are reliable and have reliable partners to whom they can refer, but who also provide them with feedback so that they can create medical homes, true medical homes for their patients, which often doesn't happen. So that's where we are. I'll take questions. Thank you.
Before we take questions, I want to remind you that at 12 noon, the emergency system is going to go off, so don't panic. And we'll take questions now.
Thank you for your speech, and I really appreciate that your time. It's good to see the person from the Chicago because I just moved from Chicago last year.
Oh.
And then I was in the field, the early breast cancer early detection field, like 8 years. And then so actually I really appreciate that you are showing that whole information. However, just I have questions. Have you had a chance to look at some role of some community-based organization for the early breast cancer early detection system? How they roll, and have you ever chance to examine their role?
Yes, in fact, as I said, we helped found a couple of them, but the Metropolitan Chicago Breast Cancer Task Force, which we work with, but they're separate from our center, has a major outreach. And actually, there's also been, we have a center of excellence in eliminating health disparities, one of the P60 that you're talking about doing. And a major part of that has been a patient education or public education program using a CD that was developed professionally with a grant from the Royal Foundation as part of the aging center we have. And that, together with, again, the Black Nurses Association of Chicago and some other outreach programs in beauty shops and churches and so forth, has done this. But the task force gives awards to community groups that do programs to promote mammography in the city, and we follow those. So yes, I do have a fair knowledge of what the community groups are doing. They're mainly education and encouraging. One of the problems is that the biggest supporter of uninsured women for mammography is the Breast and Cervical Cancer Program, and they run out of money typically in July. And they establish these programs, as Dr. Satcher was talking about. There are all over the place good programs and good policies. Unfortunately, the appropriations of funds to support these programs is inadequate. And as we were talking with some people last night, we spend the most of any country in the world for healthcare, and yet we have the poorest outcomes. And part of that is because this maldistribution. Does that answer your question?
Yeah, thank you. And I have a second question. Actually, before that, I wish that your research covers some Asian, some group.
Well, we have a very small Asian population. We're trying to work with populations where we can get population statistics that are reliable, because ultimately, if we do this, we're going to rely on the tumor registry to give us some feedback as to occurrences, for example, of cancers between screening intervals and so forth. So that we can match what's happening in these clinics with what the general experience is in similar populations.
If you don't mind, just one more question. The last year is the NHC, like a neighborhood health center, yes, of the city of Chicago, was taken over the whole facility, taken over by the non-profit organizations such as FQHC, Heartland Alliance, and some agency. And do you have any expectation what change will be happen after after the last year? And also, it's going to be what will be happen that system after 2014, which is Affordable Care Act?
Right. I think the Affordable Care Act is going to have some bumpy roads for a while, because I do not think there's been sufficient. The criteria for selecting these community health centers are population characteristics, but there's no expectation that these clinics have referrals. And one of the things that the task force has found is that the mammography facilities that a lot of these women are being referred to don't deliver the standard of quality mammography. So paying money to refer people to places that don't do a good job is wasting money and raising false hope in people and creating distrust. And those are things that are certainly going to work against success. So I think more thought needs to be given to the role that these clinics are going to play in terms of particularly chronic disease, because certainly cancer in the area of detection. There was a presentation at the summit, a really interesting presentation, of a gastroenterologist in South Carolina that took his team out into the countryside for a month, and they did 455 mammograms, and he trained primary doctors in this suburban area to do it. He could watch them on the screen, and he stayed in the room with them for a while, and then watched them on the screen. I think that's a really innovative approach, and it says that you could train primary care docs to do more screening, not mammographies. I mean, mammographies require special equipment. But if you've got things that require referral, then you better have good facilities to do that, or why do it? I mean, you're wasting money, and I think it's unethical. But yes.
Earlier in your presentation, you highlighted the importance of policy.
Yes.
I'm going to frame my question around that. Several years ago, research here in Atlanta found exactly the same data that you did, namely that comparing a disparity neighborhood with a more affluent neighborhood, the rates of breast cancer mortality were 3 times higher.
Right.
And the rate of screening was reversed, much more screening. So you found the same issue. My question is, getting at the causes of those and translating that information to policymakers, to decision makers in the city of Chicago. Was there any effort to do that? Did your center try to do that, and how successful or unsuccessful were you?
Well, as I said, that this Metropolitan Chicago Breast Cancer Task Force got Medicaid to require that these screening facilities that are getting a super payment for doing mammography with uninsured people, if they want to get that bonus, they have to provide quality data, which is being transmitted back to them. I mean, it's not made public, obviously. You never get people to do it. Our tumor registry doesn't even identify where the patients came from. If you want it, they'll let you geocode the addresses, but you won't know the hospitals. This is a very sensitive issue, in other words. But the more you get people to pay attention, I mean, I evaluated some years ago a program called the CCOP program in cancer, community clinical oncology programs. And what we found, one of the best things we found, was that doctors who participated in those programs reorganized their practices so that everybody got the standard of care, because it was too complicated to just do it for the patients that were going on protocol, which is a small number. And in the same hospitals, doctors who participated in this program, a patient who had listed on their top 5 doctors, a patient who was an oncologist, those patients, 85% to 90% of them got the standard of care, whether they were on protocol or not. Doctors in the same hospital who didn't refer to an oncologist, the compliance with the state of care was about 25%. So, and we kept them. In other words, we followed them for 3 years, and if in the first year, patients from certain practices didn't have an oncologist involved, we didn't move them into the oncology involved in the second and third year, so we could measure change if there was any in that group. It didn't change. So I do think that if you can get these doctors to think in terms of and guaranteeing them access to reliable information about the care, and enabling them to care for their patients, because a lot of these doctors come from University of Chicago, Northwestern, other places. You know, they have good training. They just don't have good information. And if you give them continuing medical education and so forth, then if that works and navigation works, then they'll be part of Medicaid reimbursement. The Act calls for navigation. Specifically, when they say they're going to set up these neighborhood centers, they say they're going to have navigators to get the patients in. I don't know who's going to pay for that. Certainly not these clinics. And I mean,
basically, my question was about the political decision makers who allocate resources to do that.
Correct. And I think that yes, I think that as these things work, there'll be pressure for that to happen. I don't think it's going to come from. I think it's going to come from the people. I mean, another program that we evaluated was the program where you could call the PDQ, Physician Data Query System. There's another cancer program where you could call this number. It was supposed to be for doctors to find out where clinical trials were being done and who was where. Well, the oncologists hated it particularly established oncologists. I called them and interviewed them myself, and my ears were ringing when I got off the phone. The young doctors thought it was a plan by then Director DeVita to steal their patients. What happened eventually was that they were made available in libraries, and guess who came with them? The patients. The Cancer Information Service told the patients that they could get information about where the best treatment or where the trials were, by this system, and it was available in medical libraries and in public libraries. And people started showing up, and it made a difference. People changed the way in which they did it for those that had access to it. Now, not everybody is plugged into those kinds of systems, and that's where navigation and these kinds of programs focused on these clinics can help. So yes, I don't think it's going to be, I don't think there's going to be a miraculous thing at the top. I think the president has done about as much as he can do with this at this point. People have to come to believe that it's going to make a difference, and it's going to reduce costs. I mean, if you get cancer early, you get women healthy enough to work, men healthy enough to work because they're not labored with chronic diseases, you're going to have a higher tax rate without raising the rates because more people are going to be paying. And you're going to be paying less for medical care. So I just think it's an evolutionary system, and I myself I don't think I'll live long enough to see it happen, but I'm willing to set some foundations for it. Yes?
Hi, Michelle Rushing from the Georgia Health Policy Center. I wanted to thank you, first of all, for coming and sharing your expertise, because there are so many similarities between Chicago and Atlanta. I think we can learn a lot. My question is, as we're talking about medically underserved areas and the lack of service in those locations, whether they're designated or not, there's two sides to the solution. There is the side where we can devote resources to providing that medical access. The other side is asking, what factors are driving the concentration of poverty and other elements that cause that area to become medically underserved. I was wondering if the task force had any researchers who were starting to look into those underlying causes or working on targeting so that the area develops its own market-based access to care.
Well, I think that's happening in a lot of communities. Actually, it's happening with migration of populations. The biggest thing that happened to promote this was the closing of public housing in Chicago. I mean, it was a terrible experience for the people who lived there because those were communities. But I was doing smoking cessation at the time, and we did focus groups with the women living in those houses, and the stories they told were just, they were certainly enlightening to me. And I mean, one woman described how she had to carry a baseball bat when she took her kid down to catch the school bus. And one day she passed somebody lying with her child, somebody lying on the floor with a needle in his neck. And so stories like this. And what they said was, I mean, we were thinking that telling them more about the badness of smoking was good. They told us it was an affordable pleasure. And that they were tired of hearing this, and they were particularly tired of having their children come home from school and tell them that they shouldn't smoke. They knew they shouldn't smoke, and they were protecting their children. They couldn't take them out. They were, excuse me, it's not open. They knew they could. They protected their children by going in the bedroom and closing the door and smoking. Well, of course, the smoke came through the door and so forth, but in their minds, they were doing the right thing. They knew they needed to do the right thing. And when we changed our program to focus on the benefits of not smoking, rather than the wrong things with it, we had a much better success in terms of cooperation with the program. So it always helps, I found, to talk with the people you're trying to help before you help them, because you may not know what they need. And I think that's true of the government too. And I think that's where this task force actually is doing a wonderful job, because they hold annual meetings where they report back to the community and give awards to groups that have made efforts and so forth. And so far they've gotten good funding from Coleman and Avon to do that. Other questions?
All right. Thank you very much.
Thank you.